Coming to the role of CT, it is the most common modality which is used in the tertiary centers for esophageal CA. And the protocol involves acquisition of CT from acquisition of CT scan of neck, chest, and abdomen with contrast, with oral positive contrast, for reduction of false positive esophageal thickening in the collapsed state of esophagus. So we have to distend the esophagus properly to know the actual thickening of the esophageal CA. And the dilution of the contrast should be done to mitigate beam hardening artifact. If we don't dilute now, there will be a lot of artifacts which will be coming from the contrast, which obscures the lesion. And if there is a high risk of aspiration, oral plain water bolus can be given. One of the drawback of CT is it is difficult to differentiate between T1 and T2 disease by CT. We can't, and paraesophageal fat infiltration, the sensitivity is 75% and 78% specific for T3 disease. And the loss of fat pain between the tumor and adjacent mediastinal structures suggests T4 disease, which shows 75% and 86%, 75% sensitivity and 86% specificity. It can predict the invasion of aorta when the lesion is encircling more than 90 degrees of the aorta. And CT allows accurate identification of complications like fistulas of esophagus with the surrounding structures. This image shows the T1 stage esophageal CA, where you are seeing that there is no involvement of the muscularis propria. There is only small lesion within the lumen, small nodular lesion. This is a stage 2 disease where there is involvement of the surrounding muscularis propria. This is an image showing circumferential thickening of the esophagus, which is showing there is a fat stranding in the surrounding fat planes, suggesting involvement of adventitia. This is the T4 stage CA, where we are seeing that there is extension of esophageal CA into the carina and into the left main bronchus. There is one more image showing T4B lesion, where there is extension of esophageal CA into the left main bronchus, and as well as encircling more than 90% of aorta. So this is the image which is showing that there is a node in the right supraclavicular region. Normally, more than 5 mm of size of the supraclavicular lymph node, we take it as a metastasis, and any esophageal abdominal lymph node more than 10 mm of short axis is taken as metastasis. So MTCT has an overall sensitivity of 30 to 60% and specificity of 60%, 60 to 80% for lymph node involvement. And false negative rates mainly is because of the fixed criteria of metastasis. And we may not be able to make out the micrometastasis in the lymph nodes. And low specificity is mainly attributed to the benign enlargement of lymph nodes due to infection and inflammatory pathology. So what are the limitations? Low sensitivity for early stage disease, need for adequate distension of esophageal lumen, no definite criteria for lymph node metastasis, requirement of whole body scan of for M staging, and a poor post-neoadjuvant chemotherapy assessment. Coming to the importance of PET-CT, in comparison to MD-CT, PET-CT is more sensitive in identifying the primary tumor, lymph node spread, and distant metastasis. And here in the image, you can see we can see there is a metastasis into the left humeral head. There is a retrocrural lymph node. There is left gastric lymph node. There is one more PET-CT image showing uptake in the retrocrural lymph node. There is one more PET-CT image showing multiple metastasis to the vertebral bodies. And for T-stage, FTG is not good because of the poor spatial and contrast resolution. And the sensitivity for nodal involvement is 60 to 96%. The limited spatial resolution of PET-CT is because of the poor identification of periesophageal lymph nodes, that the adjacent primary tumors. Coming to the M staging, PET-CT has best performance for detection of metastasis compared to the other modalities. What are the limitations? It has higher cost, non-availability in resource-poor settings, and poor spatial resolution, and failure in identification of FDG non-avid lesions. Coming to the MRI, it has good resolution, and additionally, unlike US, it is non-invasive, provides unmatched soft tissue contrast. And because of SEM Tesla, which is used in the Western countries nowadays, we can see the esophageal layers very clearly, and we can use T2 and diffusion-weighted imaging to know the CA extension. This is the cross-section specimen actually. With the 3 Tesla MRI, we can make out the muscularis propria, submucosa, as well as the muscularis mucosa very clearly. And in the C image, you can see that there is a circumferential involvement of the CA and sparing of the muscularis propria. And in the Right lower image, this is a restricted diffusion, which shows that CA is involving only the submucosa, which is a T1B lesion. It has found high specificity and sensitivity for esophageal cancer detection, and MR esophagus has found to be better at localizing and assessing the longitudinal extension of the tumor. And it has very high sensitivity and specificity compared to CT and PET CTM for T staging actually. And metastatic lymph node involvement can also be made out by T2 images and diffusion weighted images, where we can see restricted diffusion in the metastatic lymph nodes. Thank you.